Now, sometimes the soft tissue closure is not perfect. Do not be alarmed at a couple of weeks if you see a little bit of soft tissue cratering interproximally. With good home care, routinely with time, this fills in nicely. You see we've had a bit of tissue recession as we would normally expect. Our 4 mm implant is now perhaps showing close to 2 mm supragingivally. And here's routinely what the health of the soft tissue looks like when you remove the healing abutment and you're ready to commence your prosthetic procedures. I like to wait on average about 4 months just to be on the safe side. We don't rush things. When I explain to patients, if you want to play it safe, we'll wait longer. I yet to have a patient who says, no, I want to take a risk. I want to restore this right away, or I want to restore this after 4 weeks. An extra couple of months out of their life to play it safe doesn't seem to be an issue, at least in my practice. So there's that case restored. And again, what we find with these cases compared to the narrower diameter implants for single molar restorations is that we never seem to require any ridge lap. We seem to have a better emergence profile. We have smaller interproximal spaces. And we often have patients complaining with narrower implants that they love their implant, but they do complain about the nuisance factor of interproximal food impaction. So we get this much less with these wider diameter implants. Here's that case radiographically, showing you again the implant at 6 weeks and showing the final case 6 months after restoration. And you see these implants incorporate a platform shift or a platform switch, and this is that 9 long by 9 wide. Let's look at another case. Again, we remove the tooth atraumatically. Here you get a good idea of the implant positioning. We're a couple of millimeters subcrestal on the lingual and interproximal. Very often on the buccal, we're not 2 millimeters subcrestal. So there's always some scalloping. Patients rarely present with bone that's perfectly flat. Here you get a better view showing the relationship where we are 1.5 millimeters lingual to the facial bone. We're not fully 2 millimeters subcrestal here. This void probably would fill spontaneously with good soft tissue closure. And by that, I don't mean necessarily submerging the implant. I include sealing the tissue around the healing abutment as soft tissue closure. And our colleague, Dr. William Becker, or Bill Becker, used to call this getting a seal, but he called it a fibrin seal of the soft tissue to the healing abutment. We usually do graft these sites, mostly because perhaps we feel better if we can graft that, but we charge the patient very little for this very minor graft, and almost anything will work because this is a very predictable grafting situation. So the cost of this graft is 1/10 of what it might be if you were doing a separate extraction socket preservation. So there is a good cost savings as well as time savings to the patient, and of course you're saving them at least an extra surgical procedure. So here again, transmucosal healing like the previous case. We remove the healing abutment once again. This is an external hex showing excellent soft tissue health. This implant's 8 millimeters in diameter. The previous case was 9. But again, we're getting this kind of results pretty much on a routine basis with this design. And here's that particular case. And again, there's still some remodeling of the graft that we place. You can see radiographically. Well, the maxilla is no different. Here's a case, and again, routinely trisecting the maxillary roots, removing things atraumatically, one root at a time. You can see here the floor of the sinus. We have a fair bit of bone to work with here. We have other cases where we have far less, where we can still manage. This happens to be only 7 millimeters in length, 8 in diameter, at the time of initial placement. And here, 4 months later, you see the bone remodeling and the final restoration. And here you can clearly see the platform shift we're talking about, and just a great service for the patient. Here's that same case clinically. Again, what it looks like with the healing abutment removed, and the facial view, and the final view. But every system sometimes has some little challenges, and it wouldn't be fair and honest if we didn't include some compromise results with this particular implant design. And this again can be categorized. You see I've got 4 categories there. So let's look at just a few examples, starting off with the problem with unseated abutments or lost abutments. Because on this particular implant design, and this is the external hex system, 9 millimeter diameter, where the specific contour of the healing abutment bevels out, on occasion we impinged on some of the bone, especially if the implant was placed subcrestal. This wasn't a big problem. We could remove the bone judiciously, or just at the post-ops, tighten that healing collar, because that bone, interfering bone, would actually slowly resorb under the pressure of the healing abutment. So not a huge problem. And frankly, I think this was more of a historical problem when I used the external hex implants. And I haven't seen this problem now that I've gone over to the Straumann wide neck type. Again, those are called the Max IT implants. We've even seen on occasion in the final restoration where the definitive prosthesis was not fully seated. But I also like to show this case to show you how even here, look at the floor of the sinus. We've got barely 6 millimeters of bone here, yet we can do this case with an immediate Max implant without sinus grafting. We can just bump up the floor a little bit with that smooth dome on the top without tearing the Schneiderian membrane. This is a 7 millimeter length implant, 9 in diameter. You can see this implant is almost like a ball when you get to this size. And I would caution you that when you place this implant, if you go after you've used the handpiece placement and you want to turn it slightly more with your wrench, you do need to be careful that you don't change the orientation of the implant. Again, you're not dealing with a deep, narrow osteotomy where there's no way you're going to change the orientation. But in a case like this, where you do not have complete congruency with the bone all around the implant, and you've got an implant that's more like a ball and less like a long, narrow one, if you're not careful, you can actually turn the implant slightly, and I think I did that in this case. So you can learn on my experience, because I knew when that implant went in with my handpiece, it looked perfectly straight to me, yet in the final analysis, it ended up being slightly tilted. Here you see the healing abutment on. But it also, I like this case from the point of view of how we managed with very minimal available bone. But you can see even in the final prosthesis, the crown on the mesial does not look fully seated, or the abutment actually. I think this is similar to that lower molar case I showed you where we were in the distal root, where the dentist may have used a one-piece implant and abutment and had difficulty with the path of insertion. And I do believe this could have been corrected with a two-piece system, a customized abutment to correct the angulation, and a separate implant crown placement. But again, the angle was off a bit, and I do caution you not to change the orientation, especially if you're going with the wrench after your handpiece placement. This is something that's anecdotal, is there a concern of having two large implants placed right next to each other? Going back historically when wide diameter implants were introduced, and early on some people were reporting on higher incidences of crestal bone loss, one of the theories for that was that the implant itself is in effect an avascular object that you're putting in a patient's alveolar ridge that interferes with the patient's blood supply. And after you put that blob of avascular titanium in the bone, the body must reform its blood supply and reform a collateral circulation around that. So the bigger the implant, the more challenging it is for the body to heal, and perhaps if you thin out the bone a bit much, you can have bone loss. Well, what if you put two avascular objects, very large ones, next door to each other, even if they're 2 or 3 millimeters apart? Perhaps that's a challenge to the healing process. So for now, we are recommending that if you're using these large implants, do not do two adjacent large Max implants unless you're separating them, in my opinion, by 4 millimeters or more. I'll show you just two cases to demonstrate this. These two molars had to be removed, and I did place two adjacent Max implants. The mesial one is 9 diameter, the distal one's 8. But even after 5 months, we had a challenging healing of the soft tissue. A case of one does not make a scientific study, and actually the bone looked very good. And we actually have not been able to get this patient back for follow-up, as is a common problem as a periodontist. Once they have their implants restored, they don't want to see me anymore. So, but in speaking to others, they've agreed that this is something that if you're going to do two adjacent implants, as in the second case I'm showing you, try to spread them apart further if you can. Otherwise, I would do them one at a time. Let one heal, let the blood supply reestablish, and then do the second. In this particular case where the implants were further apart, again, you see there's no challenge, no compromise in the soft tissue healing. Another bit of my learning curve is I tend to look to the 8 millimeter implant as my default implant and only look to the 9 millimeter implant if I'm sure I have the bone available for it. So I think that in the beginning when we use wide implants, we sometimes get too aggressive and maybe go with a 9 when we should have gone with an 8. We end up maybe thinning the bone a bit, maybe compressing on the bone a bit. Then we end up getting some bone loss, recession, and maybe a little implant exposure. So let me show you a case where I did this. Here's this second molar we need to remove. You see the radiograph here. We've got lots of height, so I'm going to put in a long 11 millimeter implant, but it's 9 in diameter. And in hindsight, I would have gone with an 8 because this is the buccal view, and you can see the gray metal showing. Part of that first level of gray is the abutment, and the little line of gray closer to the tissue is actually the top of the implant. And palatally, similar situation. Now, is this a concern for the longevity of the implant? I doubt that it's a concern. Is it a cosmetic issue? Obviously not, but certainly I think we should try to avoid this. So again, I don't often go to the 9s. They're there for the odd case. What about malposition of implants? I already alluded to mesiodistal malpositioning with those short, fat ones that with the ratchet, if you're not careful, you could perhaps reorient. Apicocoronally, let me show you a case where we needed to remove this tooth. And as you look at this initial placement, it looks pretty good. Certainly on the mesial, we're well below the interproximal crest of bone, but we have a big discrepancy on the mesial interproximal bone height level and the distal. The distal's much more apically positioned. So on the distal, we're just barely at crest. This is the day of implant placement. Let's see what it looks like as we follow it up. We're getting a little bit of bone remodeling, and now we have a thread exposed, even after 6 weeks. And when we look at it 4 months later, we have almost 2 threads exposed on the distal. And when we look at it 5 months after restoration, we've stabilized at the second thread. Not a huge issue. Don't think it will impact the long-term prognosis of the implant, but be aware that we want to try to get the implant usually 2 millimeters subcrestally on the interproximal and lingual aspects or palatal aspects. Typically, that means you're not that far below crest on the buccal in most situations. Here's that case clinically that looks fantastic, but again, radiographically, it was imperfect. So in summary, with immediate implants in general, in all areas of the mouth, I think we can confidently say that based on the evidence in the literature, certainly based on my own experience, they definitely can work. Of course, you need to do your case selection properly. If you've lost your facial plate of bone, I would not consider that a good case. We want the circumferential bone intact, for example, no huge periapical lesions, and so on. What are the advantages of immediate implant placement? I cannot overemphasize the importance of increased patient acceptance. Patient and dentist really both benefit, and I even think that you can get improved clinical results. In terms of specifically that Southern Max implant, I do think this design offers some unique advantages, but there are some unique precautions as well. The unique advantages is that with the molar extraction sites, we can more predictably get initial stability, fewer cases that you'll have to abort due to lack of initial stability. And that aggressive taper, I think, is well designed as well, because as we go apically, for example, in the posterior molar, we're into the mylohyoid lingual undercut, and we have less risk of perforation through the lingual cortical bone. Because we have such a large diameter implant in what is a pretty large extraction site, we have a smaller peri-implant void compared to using a narrower diameter implant. And I think this reduces the amount of grafting we have to do. It reduces the number of times we have to submerge and do a 2-stage surgical protocol. And it reduces the need for releasing incisions to get a decent soft tissue closure, even if we're doing a non-submerged protocol. I do also believe the wider platforms of 8 to 9 millimeters in these molar sites do improve biomechanical stability because we have a larger prosthetic table. We can incorporate a fair degree of platform shifting, and many of us feel that that can reduce crestal bone loss because we're taking that micro gap, moving it away from the bone, and moving it on top of the horizontal prosthetic table. And lastly, again, to summarize, there are some precautions that are specific to this design. We do need long-term studies. We do have to make sure that we stay lingual to the facial plate of bone. We want to perhaps not be too aggressive with the 9s, as I mentioned. The 8 is my default. The 9 can be a rescue or just salvage for very select cases where we know we have lots of room. As I mentioned, be careful with the orientation of your small round-like implants if you're going with the wrench. Like any implant, be careful not to over-torque with the wrench because you can strip the thread. This can happen with any implant, but sometimes with the short, wide implant, especially if you don't have circumferential bone congruency, it might be a little easier, so don't overdo it on the torquing. And other things that are, I think, for any implant, if you have significant bone defects, if you have narrow ridges with total lack of keratinized tissue, those are issues you have to be on the lookout for. So again, my name is Murray Arlen, full-time periodontal practice in Toronto. Want to thank, again, Dental XP for allowing me to share this presentation with you. And as I mentioned, it's the second one we've done. The first one is actually on narrow diameter implants. And again, you can access that in the archives. Thank you for your attention, and I hope you enjoyed the presentation. Bye-bye.